So we're going to finish with our heart blocks, asystole, and a little more information about PEA, and again, especially as compared to pulseless electrical tachycardia. So what are heart blocks? Simply put, they're just delays in the electrical conduction system between the atria and the ventricles. Normally, if we're talking about the SA node to the AV node, we say that that AV node is kind of that yield sign that allows time for the ventricles to fully dilate and then fully contract so we can maintain cardiac output. Generally, these delays in conduction will probably start in the AV node, but you can also have delays in conduction in the bundle branches. You can see that differently as you're moving further into critical care areas. You can have various heart rates when you're looking at heart blocks. First degree heart blocks, you will always have an underlying rhythm, so it could be a sinus brady, sinus tachy, or just normal sinus. But generally, as you progress those heart blocks, because we do have a process where you're going to be missing some QRS complexes, will tend to be more Brady than anything. And we'll look at some of the medications that are going to slow down that kind of electricity. So if we do have a client that is trending down heart rate-wise, we can do a simple investigation to their electrolyte and their MAR. So generally say we understand it's going to cause some sort of bradyarrhythmia, and that's going to lead to a decrease in cardiac output, which can be our perfusion words, so dizziness, fatigue, agitation, syncope. Long term, we told you, or we will tell you, that generally people don't die because of the MI. They die because of the dysrhythmia or whatever other phenomenon is going to happen because of the increasingness of those heart blocks. You can see it on telemetry. If you have like an accelerated heart block, so if you had secondary type 1, secondary type 2, and it's still maintaining like a heart rate of 60, it may not be as noticeable. But as long as you're using your toolbox and measuring your PRIs, you're going to be able to see quickly how that PRI is going to change from each presentation of first degree, second degree, or complete heart block. And again, it's my job as the nurse to make sure that I am doing my toolbox to make sure that I do recognize these heart blocks early into that patient's admission. So I always like to see things that are meaningful and will help me to learn how to differentiate various material. So the way I do it here is we are talking about our PRI. Most heart blocks are probably somewhere in that range. So we're going to measure that PRI. So if you have a consistent PRI and it's always the same and always greater than 0.20. So first degree AV block, that would be our normal underlying rhythm is a sinus something with a first degree AV block. So just like we talked about with PACs and PVCs, first degrees always have something underlying. In this particular instance, it looks like their heart rate somewhere between 60 and 70. But what you notice down here in the green lines is that this PRI is prolonged, but it's always the exact same distance from the QRS. So I have a consistent PRI. And that's how I kind of remember, because we're going to go consistent, inconsistent, consistent, inconsistent. So that's a first degree. This is a second degree type 1, and you may have heard the Winky Bach poem, longer, longer, drop a beat. Now you have a Winky Bach. So what we're looking for here is an inconsistent PRI. Typically, it's going to trend towards greater than 0.20, and will get progressively longer. So what I see here is I start off with a very good-looking PRI. I notice that the next one gets significantly longer. When I compare it to the next one, it gets significantly longer. What I want you to notice is that even though the PRI is becoming long, you still have a consistency in the R to R. So you're still able to maintain some sort of cardiac output. Finally, once we have enough in the heart, just trying to figure out what's going on, what you're going to see is you're going to see this lonely P without a QRS. It should have come here, and it's missing its friend. So you're still able to maintain cardiac output. The PRI is consistently longer. It's longer, longer, drop a beat. For second degree type 2, what you should see is a consistent PRI if there is a PQRST. So as we're moving along here, you see that the PRI between these different QRSs is the same. But yet again, I have this random P wave. And then the QRS should have come back in about the same place. I have now another P wave and a QRS that matches my first three. So the heart rate, you can still see that it is okay, but it's 50. Long term, once we get to second degree type 2, if we don't find an underlying cause, if we think that this is something that's going to turn into a chronic situation, we'll probably start thinking about some sort of permanent pacemaker. But be prepared. If we can't figure out what's going on with this, we may have to do some external pacing if they are starting to have issues with perfusion. So finally, I have my third degree or complete heart block. And what you'll see here is just a total disassociation between the P and the QRS. So this first one here, the P actually follows the QRS. You can imagine how bad that would be. Here we do have atrial contraction, but we have no ventricular response. Here the P wave comes right before the QRS, and you have another P wave by itself. And then you have this lonely P out here, and it's really far away from the QRS. So there's no association between what the atrias are doing and what the ventricles are doing. You can see that their heart rate is only in the 30s, and probably this client is headed towards a permanent pacemaker. Don't worry, we're going to go over all those again. So, first degree AV block, progressively longer PR interval, but we do have a responding QRS. Here you can see that you do have, let's see, about 0.26 or 0.28 for your PRI, and every other one is consistent with that number. And then I do see a skinny ventricles. Those bunny ears do tend to tell me that there could be a bundle branch block there. And again, it's just delays in conduction. you will have a regular underlying rhythm. A lot of times this is benign. We can just monitor our patient. We can check their MAR, check their labs. Again, there are medications that are going to slow down electricity. Right? That's how we're going to lower their heart rate. So you think again, your calcium channel blockers, your beta blockers, amiodarone. There are also drugs not in the cardiovascular world that will also slow down the conductivity in the heart, and you will have a prolonged PRI. So here's kind of what you see. You saw that progressive longing in the PRI. Second degree type 1. So what we talked about here is this PR interval that is gradually growing larger and larger. Longer, longer, longer drop a beat. Longer, longer drop. Now you have a winky bop. However you want to remember it. It can be transient, but again, if your heart rate tends to drop too much, you can have issues with heart rate, blood pressure, dizziness. So we just want to continue to monitor that. In the illustration, so we have PQRST, and we see here, and then we compare it to the next one, and we notice that it is getting longer, longer, longer. And it doesn't always have to be longer, longer, longer. It could be any mix of longers until you have a dropped QRS. So kind of what we're showing now is that other example of it doesn't have to be longer, longer, longer drop a beat. I see that initially I don't have enough information for this first PQRST. I think this is a P, and I have a dropped QRS, but I need more information. So now I do see a P associated somewhat with the QRS, so it's 0.24. And then the very next one is 0.40. And then, oh yes, this does look like our very first one. So I'm fairly confident now that that was a P wave. Now I have another P wave, and I have another dropped QRS. And then you can see how the body picks up, and it starts that whole process over again. So second degree type 1. We've talked about medications, digoxin, beta blockers. There's a ton out there. I don't think that that's something that I would ever ask you guys indirectly to pick from a list of medications what slows down electricity. But I can certainly say, hey, the nurse is caring for a client and notices on the ECG that the PRI is getting progressively longer. Which action should the nurse take? We talked about really the only thing I can do as a nurse is to check the MAR, check the electrolytes. You can certainly get a 12-lead ECG, and then we can see if anything like ischemia or structural changes are causing the issue with the heart block. So here is what it looks like on a continuous tracing for a real client. So I notice that my R to Rs are fairly consistent. That's probably just more a process of, can't really tell what's a small box and the big box here, so my R to Rs are consistent. And then I do have this lonely P wave. Let's see, I've associated with the dropped QRS here, because my next QRS should have come right about there. And then it picks up again, and you start to see issues in the R to R as it's moving along. And then finally, I have another dropped QRS. So this client's heart rate somewhere in the 50s, 60s range. It can be harder to look and find those heart blocks, but you have to do your very best. And usually, the monitors are pretty good, and they will tell you that you probably have a prolonged PRI, which will genuinely make you go and do more investigation. So, second degree type 2, we've talked about it's the PRI is constant, but you will have more P's than QRS's, so you'll have sudden dropping in the QRS. It's generally more serious. It can progress to a complete heart block, and pacemakers are often required. So here we see that this client obviously has some cardiac issues. I do see a P. I see a widened-ish QRS. I see a depressed ST segment, and I see an inverted T wave. So I already know, because I've looked at my client's chart and I've done all my investigations about this client's cardiac history. It's either going to be heart failure, it's going to be post-MI, structural changes due to any of your inflammatory disease processes, things like that. But every time I do have a PRI and there is a QRS, that PRI is the same, again, until I have those dropped QRSs. So again, we see another interpretation. We can see random P waves that are highlighted there for you and how they're missing their QRS partners. So you can be stable. You can tolerate this if it is indeed transient, or if you do become symptomatic. Again, this is probably something that I would want to have external pacing available for. Then they're probably going to go and get a transcutaneous, so permanent pacemaker. I put this one here, and I want you to notice the little tick marks up top. So this isn't a 6-second strip. It's only a 3-second strip. So when I look at this, my heart rate really is only in the 40s here. And this is why we would lose all that cardiac output, because over time that second degree type 2 has gotten worse and worse, and we're trending towards a complete heart block unless we intervene. Complete heart block, again, total disassociation, total chaos between the PRI and the QRS. It's not too hard to identify your complete heart blocks. Again, usually they will be some sort of bradyarrhythmia, but we will show you again. So here is my first P, and then there's no association between that P and this QRS. This one's actually smaller than the first one, so that PRI is smaller. This one's all by itself. This one is right next to the QRS. You have another lone P wave, another one that's a random distance away. So typically I would look at this and probably call this an accelerated, because even though we are in that complete heart block, you do have a rate that could potentially maintain cardiac output, but the problem is your body is compensating with the ventricles here, and that compensation isn't going to last forever. That's why we say, generally speaking, if this is going to be something that we think is going to continue to happen, we're going to put a pacemaker in. Lots of clinical associations, but pretty much the same as with everything else. Clinical significance, you can be having these issues because of a decrease in cardiac output with subsequent ischemia, issues with heart failure, issues with shock. Symptom-wise, we talked about syncope and severe bradycardia. You can have periods of asystole. And again, we talked about our treatments. And the big one for this is a permanent pacemaker as soon as possible. So this is another third-degree AV block. And again, it's just illustrating all the points that we've already talked about. So P, here's a P. Just total chaos. And here it is on a real client. So the nice arrows point out the P waves. So if you look down in the second one, you can try to find those on your own, and you can see that there isn't a significant ventricular response. It looks like their heart rate is 30, 40, 40s to 50s-ish still. Asystole. Here's what I want you to remember about asystole. It's not one of your medical shows. You're not going to come in and be a superhero and shock somebody with asystole. You have to perform CPR until you get return of spontaneous circulation, ROSC. And then, once they have a rhythm, we can shock it to remind it wants to beat in a rhythmic pattern. Generally speaking, it's not even going to be a flat line. It'll be more indicative of the one on your lower left, so you'll see those waves. And then over here, I put this one up here because this is actually a complete heart block that is progressing to asystole. You notice about halfway through, I just lose all my QRSs. And that's why they're not going to maintain any kind of cardiac output, and the person's going to die if we don't do something. That's very emergent. Slap that transcutaneous pacemaker on them, call for help, get your rapid response team, and then probably get them prepped for surgery. PEA, we've talked about this. It's pulseless electrical activity. It's really not testable from my perspective, but I do want you to understand that it could potentially be on NCLEX. You just need to understand, again, that we need to do CPR. All right, and we can do medications until we get that return of a pulse. So you want to correct the underlying cause. If it's a tachycardia, so a pulseless ventricular tachycardia, you can shock that. And that is the biggest difference, and it's all about the wording. If you see it on NCLEX, please remember that there's a difference between PEA and pulseless ventricular tachycardia. So we know that for every minute that defib is delayed, the client's chances of surviving. VFib can drop by 7 to 10%. So if we have those really bad dysrhythmias, we lack perfusion. So we've talked about making sure you don't confuse PEA with PVT. You have electrical chaos and pulseless VTAC, VFib. So there is electricity working there. For pulseless electrical activity or asystole, you really kind of want to try to look at those H's and T's, and there are a lot of H's and T's. These ones, the 5, I think are just the easiest to remember off the top of your head because it's pretty much the same. It's hypovolemia, hypoxia, acidosis, potassium, temperature, blood sugar. And then you have your T's, which is your toxins, cardiac tamponade. I told you we would talk about that again, and our inflammatory disease, tension pneumo, and then you have your thromboses or your traumas. Again, it can be harder to correct a lot of these. I don't know how we go about correcting trauma. It's probably just addressing whatever the trauma was, and if they're bleeding, making sure that we're stopping the bleeding. That is going to lead to all these other H's and T's. And that's it. Very short, very brief. Big takeaways, make sure you understand defib is best. And if you have the choice between defib and CPR, it's going to be defib. But if you don't have defib, it's going to be CPR. Call, do the whole process. Hey, are you okay? Call for help. So if you find them before you start CPR, you can initiate your code, get your help there, and then we can start that whole process.